From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. We all know that atrial fibrillation is associated with increased risk of stroke, but new research suggests that how we define AFib, the timing, the duration of the arrhythmia, may be important for how we manage it in stroke patients. Luciano Sposato is our guest this week. He's a professor of neurology and head of the stroke program at Western University in Ontario. He'll talk about the latest research into afib and aflutter after stroke and how this research might impact current clinical practice. Dr. Sposato was interviewed by Dr. Christoph Stretz, vascular neurologist at Brown University. Here's Christoph.
Welcome, Dr. Sposato. I really appreciate you joining us this afternoon on the podcast.
Thank you, Christoph. Pleasure to be here today.
So we've heard that atrial fibrillation comes in different shapes and forms and that it has a complicated relationship to stroke. To start us off, can you tell us how AFib is defined and how do you agree with that definition?
Yeah, atrial fibrillation is defined as 30 seconds on cardiac monitoring or the entire 10 seconds of a surface 12-lead ECG. Of course, it has to show the typical findings of atrial fibrillation, such as the absence of a P wave and irregular RR intervals. In terms of whether I agree with this definition, it's important to note that it was established more than 20 years ago by a European group of several scientific societies, and they came up with this 30-second definition, which I think at that point made sense. But now with so many implantable devices and the widespread use, we know that maybe between 30 seconds and 6 minutes, most of the episodes that are detected are not actually AFib, but just noise or supraventricular ectopy or other types of arrhythmias. So at some point, in my view, it will need to be revised and redefined. In terms of the utility, I think it's important to have a definition such as the one with 30 seconds. We need to have a threshold because that's what we are using for clinical trials, both for including or excluding patients and also as a primary endpoint, for example, in trials of ablation therapy. So to summarize, I think we need a definition, but in my own view, I consider that it has to be revised because it's kind of arbitrary.
Thank you. So we've heard about 10 seconds. We've heard about the 30 seconds. The time that a patient is in AFib, now whether this is an absolute or relative time, is commonly referred to as the AFib burden. How does that burden that someone is in AFib inform the risk for systemic embolism or stroke?
I think it's very relevant because the longer the duration of AFib or the higher the burden of atrial fibrillation, the higher the risk of stroke and systemic embolism. So it is important. It is important to know if it lasts 24 hours or more than 24 hours, or if it lasts a full week or less than that. The important thing is that based on the ASSERT trial and then later trials, historically, we understood that atrial fibrillation lasting less than 24 hours is not as high risk as that lasting more than 24 hours. So any AFib lasting more than 24 hours is equivalent to a 12-lead ECG detected atrial fibrillation, which means that it's very high risk and there's no question that those AFibs require anticoagulation. For atrial fibrillation that lasts less than 24 hours, then in general, we consider them lower risk, but it is important to consider AFib burden in the context of comorbidities and risk factors. And why do I say this? The main reason is that if we have short-lasting atrial fibrillation in someone who has a very high-risk CHA2DS2-VASc score, there are quite a number of observational trials or observational studies showing that the combination of atrial fibrillation burden and risk factors increases stroke risk. So it's not only thinking about AFib burden, but the whole context of the patient and the medical history in terms of comorbidities and risk factors.
Thank you. So both comorbidities are important and the AFib burden is important. If we have a patient who has a stroke and we are considering cardiac monitoring, what group of patient with stroke what subgroups would most likely benefit from cardiac monitoring to look for AFib?
That's a great question in terms of clinical implications. So in general, those patients that will benefit most are the ones who have stroke that are likely caused by embolic mechanisms. And we can identify these patients based on those that have cortical symptoms on examination or on presentation to the emergency department, or those who have infarcts on neuroimaging studies that involve multiple territories or large or medium vessel occlusion or multiple infarcts. So those, there's no doubt that will benefit from finding atrial fibrillation, because in the absence of a competing cause, if we find a relatively high burden atrial fibrillation, it will be most likely the cause of the stroke. In terms of patients with a clearly established cause, such as those who have severe cardiac stenosis or a very clear lacunar stroke caused by small vessel disease, I'm not that sure that monitoring or looking for atrial fibrillation is that helpful, because it may cause some trouble in terms of the decision-making process for secondary stroke prevention. But we can touch on this later and discuss it more in depth.
Thank you. So after we've kind of discussed, who would benefit, now, if you decide you would like to monitor a patient for AFib, how do you do that in your practice, and how long would you monitor a patient if you suspect they might have AFib?
Yeah, that's another nice question in terms of clinical implications. Yeah, and I think it depends on what is available at each institution, right? For example, in Ontario, we have 14-day holters, but implantable loop recorders are not covered by OHIP, which is the universal healthcare system, right? So we are not able to use longer cardiac monitoring, even if we want to, because in general it's not covered. So we use 14-day holters, which have the same cost as a 24-hour holter. And if we have a very high suspicion of atrial fibrillation and the first 14-day holter did not show atrial fibrillation, then in that case, we will repeat another 14-day holter, and maybe we would do another or a third 14-day holter. There are several situations in which I think it would be very helpful to have an implantable loop recorder. For example, if we think about patients who have a stroke and then they develop atrial fibrillation post PFO closure, in those cases, it's really very difficult to know exactly when patients stop having AFib and when anticoagulants can be stopped safely without being at risk of causing another stroke. So in those cases, I really feel that it would be much better to have a much longer cardiac monitoring device than the 14-day holders that we have to repeat several times per year. And then there are some patients who keep having recurrent strokes. They have ESAs or embolic strokes of undetermined source, and we do 1, 2, 3, 14-day holders, and we can't find atrial fibrillation. In those cases, if we ruled out cancer as a potential cause, or if we ruled out other sources of cardiac embolism, such as valvular heart disease, or by doing a transesophageal echocardiogram, or a cardiac CT, or a cardiac MRI, I think the only chance is to find atrial fibrillation. And in those cases, I would really like to have an implantable cardiac monitor.
I'd like to pivot a little bit into what we've seen with prolonged cardiac monitoring, that while the trials have shown that the longer you monitor, the more AFib you will eventually find, and that if you do find AFib, that it also was associated with increased initiation of anticoagulation, but not consistently really with a reduced risk of ischemic stroke. I'm curious if you can sort of summarize for us what are some of the key findings of two recent trials, the Artesia and the NOAA AFNet6 trial, and how they implicate the practice.
Yeah, so Artesia and NOAA AFNet6 are two clinical trials that were quite similar, but not exactly the same. In NOAA AFNet6 trial, they enrolled patients with atrial fibrillation detected on implantable devices, and they randomized them to receiving edoxaban versus aspirin or placebo. Patients would receive aspirin only if there was a clear indication for aspirin, otherwise they would receive placebo. And then the duration of atrial fibrillation had to be between 6 minutes and 24 hours, because those are the durations that, until these trials were done, were considered low risk, and there was no clear indication for anticoagulation. In the Artesia trial, they included patients with the same type of atrial fibrillation, but they randomized them to receiving apixaban versus aspirin. And then in terms of the primary outcome for NOAA-IF-NET6 trial, it was stroke, systemic embolism, or cardiovascular death, compared to Artesia, in which the primary endpoint was stroke or systemic embolism. So those are the main differences. In terms of results, NOAA-IF-NET6 was stopped prematurely because of concerns about in bleeding risk, major hemorrhages. And by the time it was stopped, it was also found that it was unlikely for the study to show any benefit in terms of anticoagulants being better than aspirin or placebo. In terms of Artesia, it was stopped earlier, but regardless, it did show a benefit for apixaban compared to aspirin in preventing the primary endpoint of stroke or systemic embolism. And the interesting thing is that it also increased the risk of causing major hemorrhages by about 80%. So in the 80% in the as-treated population, it was slightly lower in the intention to treat population. So there was a meta-analysis combining both trials. Actually, it was a study-level meta-analysis. It was not a patient-level meta-analysis. And it showed that, in general, results were showing findings in the same direction, suggesting that if NOAA-IF-NET trial had enrolled more patients, it could have possibly been positive. My take is that I'd like to have more or a higher number of studies when I do a meta-analysis, so I would just consider that with caution. The most interesting part for stroke neurologists is that in both trials, Artesia and NOAA-IF-NET6, there was approximately 10% of patients who had a prior stroke or TIA. There were pre-specified sub-analyses done for both trials. In both sub-analyses, the results were in line with the main study, showing similar results. But in Artesia, it showed that the benefit of anticoagulation compared to aspirin was a bit higher, suggesting that because patients are at higher risk of having strokes, the benefit of anticoagulants is larger than for patients without a prior stroke. The issue with this is that there are several important aspects that we need to understand about these trials that I think hinder generalizability. So, for example, if we consider the type of strokes that were included in the Artesia trial, there were some patients with hemorrhagic strokes, and there were some patients with strokes of undetermined cause. For example, it was not possible to know if those patients had a hemorrhagic stroke or an ischemic stroke. So it's not the same to consider a population with acute ischemic stroke and a population with TIAs and prior hemorrhagic stroke. The other important aspect about both Artesia and NOAA-IF-NET trial is that the stroke that patients had, that patients had at enrollment, had happened a long time before randomization. For example, if we look at NOAA-IF-NET6, the stroke that patients had before randomization occurred 5 to 6 years before randomization. And if we look at Artesia, about 86% of the strokes happened more than a year before randomization. Another difference between Artesia and NOAA-IF-NET6 compared to studies that only included patients with an acute ischemic stroke or a recent ischemic stroke is that Artesia and NOAA-IF-NET6 had patients with a higher burden of atrial fibrillation. If we think about median minutes in atrial fibrillation, Artesia had around 4,400, and there was a similar number in NOAA-IF-NET6. And if we look at, for example, Crystal AF, the median minutes in atrial fibrillation was around 670. And if we look at Stroke AF, for example, it was around 88. So there's a clear difference in the burden of atrial fibrillation in studies with an acute or recent stroke compared to those with a remote stroke including in artesian and no IFMED6. So these are substantial differences that can influence stroke risk, and I think in general limit our possibility to generalize these results.
Thank you very much. So it seems like it's fair to say that we have to take the data that were the results that were generated in both studies with a grain of salt when we try to apply it to secondary stroke prevention. Is that fair to say?
Yeah, I totally agree with that. And I do think that we still need a clinical trial to know how very prolonged cardiac monitoring affects stroke risk and which type of atrial fibrillation we need to anticoagulate. So that is not understood yet and requires more research.
Very good. When we have, patients who, let's say they have had a stroke and we have an established stroke mechanism, but now they're found to have atrial fibrillation as well. That is, that's been detected on a cardiac monitor. How do you approach those patients when you think that the AFib is not the most likely cause for their stroke?
Yeah, well, that's a situation that I don't enjoy living with a patient because, if someone has a very clear cause, a very clear stroke mechanism, such as 80% carotid stenosis with a very bad looking plaque, ulcerated with enduring plaque hemorrhage, I don't think it's worth pursuing prolonged cardiac monitoring, because if we find atrial fibrillation, we won't know if it has a causal role or not. And in that case, in particular, will compromise secondary stroke prevention. And the reason why it will compromise it is because an ulcerated plaque requires treatment with antiplatelet therapy. But if we detect AFib, there's no way we cannot treat it if it was detected in a patient with a stroke based on current evidence. So in that case, we would not know if we have to use a direct oral anticoagulant, if we'll have to use aspirin, or if we will have to use both. So the only thing that we know for sure is that if we combine aspirin with a DOAC, we will increase the risk of intracranial hemorrhage by 37% just by adding the aspirin. So we do not have clinical trials comparing aspirin alone or anticoagulants alone, or both combined in patients with atrial fibrillation and a clearly defined atherosclerotic stroke. So finding atrial fibrillation in that case would represent a problem rather than a solution, mostly when we know that AFibs in patients with a stroke mechanism such as small vessel disease or large vessel disease are very low burden and probably low risk, as shown in the stroke AF trial. So if we find the AFib on a 12-lead ECG in a patient who has carotid disease, then that's a very different story, because that AFib is high risk and there's no other option but treating the patient with anticoagulants and probably a short course of antiplatelet therapy, although we don't have a clinical trial demonstrating the efficacy of this approach.
Great. No, those were very helpful points, I think, for our listeners really to understand it. It does matter when we detect the AFib, how we detect it, because it tells us something about the burden and obviously comorbidities and what we think in a particular patient, if that may be or may not be the most likely cause for their stroke. One other concept I'd like to turn our attention to is the AFDAS, the AFib detected after stroke, and an entity that you've described as distinct when we compare it to AFib that's known before or at stroke onset. Would you be able to kind of briefly describe why it is viewed as distinct in terms of stroke recurrence and other stroke risk factors?
Yeah, so very briefly, AFDAS, or atrial fibrillation detected after stroke, is a type of atrial fibrillation that it's only found after stroke occurrence. It's found in patients without a history of AFib, and in those that do not have an admission or emergency department ECG showing atrial fibrillation. So it's a unique AFib detected on prolonged cardiac monitoring. In general, we know that AFib detected in patients with cardiac monitors is low burden, as I said before, and it's lower risk than AFibs detected in patients who had an ECG or in those who had a history of atrial fibrillation before stroke onset. So it's a kind of lower risk type of atrial fibrillation. And because AFib in general progresses in terms of burden, and patients get older and they tend to acquire more risk factors such as hypertension or heart failure or diabetes, it is important to longitudinally monitor those patients in terms of their increasing risk throughout time. So what we have come up with is a bad risk AFDAS approach, which means that we recommend measuring the burden of atrial fibrillation in a dynamic way, the biomarkers such as ANP or atrial natriuretic peptide, which is very clearly associated with stroke risk, measuring the atrial size because it's another marker of stroke risk, and then considering risk factors and demographics such as age and sex when evaluating the overall stroke risk. It's a kind of it's a dynamic CHA2DS2-VASc score, but including other factors that are known to particularly increase stroke risk in patients with a prior stroke.
Thank you. That was very informative to hear about, how we can get to a more personalized approach in patients who have AFib detected after stroke. Well, I want to thank you for your time today and for answering our questions about AFib and a stroke. I very much appreciated you having joined us on the podcast today. Thank you so much.
My pleasure. Thank you for having me, Christoph.
That was Dr. Luciano Sposato of Western University in Ontario, interviewed by Dr. Christoph Stretz of Brown University. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our production team this month included Christoph Stretz, Michelle Johansson, and Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.